So we'll move on to the wound burn, which is a little uncommon nowadays, but we used to happen with the lower end machines, and when we used to use a lot of energy. So we'll be happily phacoing away things. And just after taking out the handpiece, you'll see this kind of whitening at the incision. So this is a very small burn here. So it may extend further till the cornea, and it can be very bad. It can cause shrinkage, all those things. So what I want you to notice is the mismatch of the incision and the sleeve. So always see what is recommended by the company people and use that kind of a keratome. So you may be using a 2.2, but the company would have given a 2.4. So we'll squeeze in instruments through that and see. This is where I want you to take a look at the incision here. This is a little tighter. So you'll see that the sleeve is a little tighter within the incision, and that will affect the fluid flow and the heat dissipation. So another point is that when you are inside the anterior chamber, if you have filled it up with the OBD, like dispersive heavy OBD, please aspirate most of the OBD above the lens before trying to phaco the lens, because that can again block, and that is also thermogenic, and it can extend the heat onto the incision. And here another point is to note the movement of the tip in the sleeve. So if you keep it straight, it's fine, but unknowingly we might move the needle towards the side. See, the whole thing is moved towards the sides, or you may lift up, or you may push down. All those situations, the fluid will not flow in between this area, and the heat will be directly transmitted onto the incision, and you will cause phaco burn. So keep looking at the incision also occasionally while you are phacoing, especially when you are doing harder cataracts, and do not use continuous energy for a long time. And when the energy is required, please use judiciously and use the modulations which are available, like burst modes with a lot of off time, and pulse modes with a lot of off time, so that you get less of heating up of the incision, use less of energy. And also the tip, when it gets blocked, when larger pieces are being taken, it may occlude the tip, and you continue doing phaco. There is no fluid inflow and outflow, and the heat generated is transmitted. And so you listen to the sound from your machine. If it gives you that ting 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 sound, it means that your tip is occluded, and stop phaco, don't do phaco. And as I said, the needle position inside the sleeve. So whatever happens, finally, it has to stop leak spontaneously after hydration. If it doesn't, 100% suture. So horizontal suture is also good. You can include that small burn which you saw there, even if the large one. Take a bite through the floor, come up onto the roof, and take another bite through the roof, and within the incision you can tighten. And after hydration, spontaneously it should not leak, and also on pressure from some other side of the limbus, it should not leak. If it leaks, put sutures. Even a 2.2 incision may need 2, 3, 4 sutures. So astigmatism may be huge, but do not care about that, because you will end up in a situation of a chronic leak and a chamber shallow and an endophthalmitis risk. So closure is the first aim, and multiple sutures so that the incision is watertight at the end. Air should not be put, because air will stop the leak, but it will be leaking once the aqueous forms again. Here again, it is not stopping. So I put another incision, another suture, and then only it closes. So with that, we come to the end of this, and thank you very much.